I'll be talking on workup of a case of incomitant strabismus. Incomitant strabismus presents with diplopia, abnormal eye movements, restriction of a gaze or inability to see in particular direction, anomalous head posture either to fuse or ignore images, and diplopia is a thing where the asset of binocularity is converted into a liability. It is a symptom which can have many potential causes and many anatomical structures involved. A goal of strabismologist here is to improve or attain the stereopsis or normal binocular single vision and alignment of eyes, preferably in all gazes. The incomitant squint could be a paralytic or a paresis, restrictive or a spastic. The examination begins with history taking, where the patient has complaints of diplopia or squinting of the eye. Age of onset is important because early onset, long duration and constant angle which points towards a surgical intervention. At times we may have to look at the older photographs to find out the cause and length of the problem the patient has. Pattern of deviation, whether intermittent or constant or changing with time, diurnal variation, precipitating factors like fever, trauma, developmental history, and treatment history in the terms of refraction, glasses, occlusion, or surgery. Assessment of sensory system involves visual acuity, fixation, binocularity, and stereopsis, and sensory anomalies like amblyopia can come only when the squint is present in early age of the patient's life. Diplopia charting is an important thing which requires a dark room, red-green goggles, and a slit light source. You have to keep it horizontal for vertical squints and vertical for horizontal squints. It lets us know whether the diplopia is uniocular or binocular. It gives us area of binocular single vision. We measure the distance between the two images. Images can be inclined or straight, showing cyclo deviation or a vertical or a horizontal squint. Diplopia can be crossed or uncrossed. And this is how a diplopia charting is mentioned, where we can have a binocular single vision on one gaze and increasing distance on the other gaze. So this is a case of left sixth nerve palsy. Assessment of motor system involves checking the head posture, detection of squint, assessment and control of accommodation because it can give variable results in measuring of the squint, measurement of angle of deviation, ocular rotations. Head postures could be a tilt, turn, or chin face up or down. The causes could be incomitant squint, AV pattern, nystagmus, one-eyed persons, or reflective errors. A single trichiatic lash can also give you a head posture, so one has to look into the patient's presentation very keenly. Also note the difference between the primary and the secondary deviation. Check the ocular rotations, note the deviation in primary gaze, look for incomitants, check the versions and ductions separately. Limitations of movement can be segregated into restriction or interaction on the basis of force duction test or active force generation test. For accurate measurement, you can use prism bars or synaptophore. It is important to measure the torsion. Subjective methods could be a double Maddox rod, synaptophore, or scotometry. Objective methods could be an indirect ophthalmoscopy or a fundus photography. Double Maddox rod involves two different rods of different colors where multiple cylinders are stacked with high plus lenses. A pen light appears as a linear streak at 90 degrees. So you have to keep it vertical for horizontal deviations and horizontal for vertical deviations. Fundus photograph of a patient with superior oblique palsy pre and post-op. Lease chart is also important. It uses the dissociation by mirror septum. One eye is fixating to the chart and other eye is being mapped. Fixating eye determines the innervational input and the excursion of the other eye. And this is how a lease chart is being done. So in this case, we can clearly see the underaction of superior oblique in the left eye and overaction of the inferior rectus in the right eye. So this is a case of left fourth nerve palsy on the Hess chart. Another Hess chart where we can see the underaction of lateral rectus on the right eye and overaction of medial rectus on the left eye. So this is a case of right sixth nerve palsy. Park's three-step test help us assess the cause of vertical squint, which could have a problem with the elevators or the depressors of either eye. So measure the deviation in the primary gaze, then in the tertiary gaze, either in the lever version or dextro version, and then with the head tilt. In this case, if we see there is a small L by R in the primary gaze, which aggravates on dextro elevation and which further aggravates on right head tilt. So this is a case of left superior oblique palsy. Role of pupil is also important because the pupillary fibers are located superficially and they are affected by external forces like aneurysm or trauma. So it is important to understand that not all cases of compressive lesions have pupillary involvement, so it can be up to 15% of cases where there would not be a pupillary involvement, but still they will have an intraocular space occupying lesion. Role of neuroimaging is also important. It is essential to rule out mass lesion in case of third nerve palsy. The indications would be younger age group, if the patient is having more than 40 years of age but with the pupils involved, or aberrant regeneration in the absence of history of trauma. It is also important to understand that sixth nerve can be a pseudo-localizing sign and harboring papilledema with a tumor in the brain. The restriction or paresis can be differentiated on the basis of force detection test, active force generation test, or saccadic velocity assessment. So this is a force detection test is being performed where the person is asked to relax and look in the direction of underacting muscle, and we passively move the muscle in that direction and assess for the tightness of the contralateral muscle. It is a passive test where the muscle is relaxed. One has to lift for the recti and depress for the obliques. Now this is the assessment of saccadic velocity. We can clearly see the excursion of both eyes, but here we can see it doesn't move the medially. So we can differentiate restrictive and paralytic strabismus based upon this table. The ocular rotations will be more on duction as compared to versions in paralytic. It will be limited in restrictive strabismus. Ipsilateral antagonist will have overaction with paralytic, but it will not be seen in restrictive strabismus. There will be a reversal of diplopia in third nerve, palsy in case of paralytic only. Otherwise, in restrictive strabismus, there will be reversal of diplopia in almost all cases. Saccadic velocity will be reduced in paralytic, however, it will be normal, and there will be a sudden stop in restrictive strabismus. Force detection test will only be positive in the later stages when there will be a contraction of the antagonist in paralytic squint. However, it will be positive in restrictive strabismus. Now, there are some examples. This is a case of post-cataract surgery inferior rectus underaction. We can clearly see the cause here could be a trauma because of needle, hyaluronidase, xylocaine, or sensory cane. Another case where 35-year-old male with ptosis and diplopia for last 6 months with diurnal variation. He has free FDT and AFGT shows poor tug, so probably there is a underaction of superior rectus. And this is the 9 cases of this patient. The patient undergoes neostigmine test. We can clearly see he's aligned. So this is a case of myasthenia gravis. Another patient which is showing bilateral 6th nerve palsy with limitation of movements on both sides. And on the fundus examination, we find papilledema. The patient is sent for neuroimaging, and this is a large tumor the patient is harboring. Another case of complete third nerve palsy where the cause is clearly seen. The cause is a herpes zoster, so we need not evaluate this case fully. Another case of third nerve palsy with pupillary involvement with a history of hypertension for last 7 years. So the patient is sent for neuroimaging and she harbors a posterior communicating artery aneurysm. A case of left traumatic third nerve palsy, important here is to see the aberrant regeneration because on adduction there is elevation of lid. So this can be utilized in managing surgically this case. Thank you.